So welcome to today's session. Thank you, Nanette. The next slide. The reason for these webinars is to make everybody aware of the fact that SafMed firstly has access to information and products that are surgically oriented, but more importantly that we can teach and share with you what we've learned around a variety of surgical items. And I think we have access to a lot of knowledge, and we really, as a team, as you know, like to share information. Thank you, Nanette. There are 5 webinars in the surgical webinar series. We have started with webinar 1, which focused on preparing for surgery and developing the bad habits and how those bad habits could have negative effect on our patients' care. Last week, we had Briette Toy discuss the importance of monitoring in the operating room environment, what we need to monitor, why we monitor these things, and the importance of keeping our patients safe and as far as possible infection-free. Today is the 29th of October, and we'll go into details of what we are covering shortly. Next session will be the 5th of November, and then the last one in the surgical series will be on the 12th of November. Thank you, Nanette. In today's session, which Nanette's kindly summarized for us, is in the term take care, and that's really what it is about today. It's about taking care both of our patient and of ourselves at the end of the day. We're going to begin by talking a little bit about the keenness of a surgical blade and the importance of preserving that and managing that. Information shared with us by Swan Morton. Then, of course, onto the surgical pause, timeout and fire safety. Then I want to focus on spinal surgery and the risks associated with spinal surgery, leading into adverse events and surgical patient safety, and finishing off with our mental health topic for today on emotional intelligence. Thank you, Nanette. Now, there are a number of ways in which the cutting edge of a surgical blade or scalpel can become damaged once it's removed from that protective foil packaging. And that damage generally will lead to the loss of the initial keenness. And the keenness, of course, is the ability of the blade or the cutting edge to cut properly. These are obvious. You know them. I don't think there's a scrub sister alive that shouldn't know all of these. But just to remind you that all of these minor but important aspects play a big role in how your surgical blade will perform. When you're opening the blade, please make sure that it doesn't make any contact with metal. So don't drop it onto a hard surface. Don't drop it into a kidney dish. That can really damage the keenness. When you're loading the blade on the scalpel handle, be very careful again with the metal contact. If you are using a forceps or a needle holder to load with, make sure that the needle holder is over the actual cutting edge. During surgery, it's quite obvious if you make contact with bone or granular tissue that it's going to destroy the keenness of the edge. And also excessive lateral pressure. That was one that surprised me a little bit. And of course, it's nothing that we have control over. That relates to the surgeon and the surgeon's technique. If we look at the next slide, you'll have a microscopic view of what happens to a blade if you drop it into a metal tray. And that's only dropping it once into the metal tray, so that's just one contact with hard metal can really and truly destroy the keenness of a surgical blade. And then often we end up with complaints about blades not working, and sometimes it's just that we've made an error along the way. Okay. So that's just a short interlude into the keenness of surgical blades. A very important thing and close to my heart is the surgical safety checklist. When this was first put into play, at the time I was a unit manager actually at the neck care group, I thought about the concept and I thought, no, this is stupid. Honestly, that was my initial thought. And my initial thought around that was not that the concept was stupid, but that I was worried about how we would put it into place. And that a surgical safety checklist is a very, very effective system. We know that. It's well proven. And of course, it was put into place and developed after lots of consultation, and the whole idea is to decrease errors. The whole idea is to decrease adverse events, and it has been shown to reduce morbidity and mortality around the world, and we know that. But for me, if you don't use it properly, and it's merely a checkbox or tick box that the floor nurse fills in, and nobody actually looks at these aspects and nobody actually puts them into play safely, then it's always very disappointing. So the concept of the surgical safety check important. I know a lot of people have incorporated it into their perioperative forms. Some people have visual displays. I've been watching some amazing videos on the internet of staff doing this and under real life settings, and it is quite interesting to watch the Americans put it into play, and a lot of people do it properly and thoroughly, and I do hope that in the future we will be doing that, because it is a very important concept. In the next slide, we will see a published paper. Most of today's reference papers are from the Association of Operating Room Nurses, some of them from the American Journal of Infection Control, but a lot around what the ARN has to say. And in this publication in 2019, the article discussed the importance of the surgical timeout and the statistics that justify it. In this particular data that they had collated, it was between 2015 and 2018, there were more than 3,300 sentinel events of these kind of surgical errors, and of them 440 were wrong site surgeries. So 440 wrong site surgeries may not seem like a whole lot, but I got to tell you, if you're the patient, it is really quite a significant number. In Pennsylvania, they had found in just under a year they had 60 wrong site surgeries, and some of them also related to nerve blocks being administered to the wrong side of the patient. I've never experienced that as a scrub sister or a theatre matron, but that is something to be concerned about. We've definitely, I've been involved in surgery where we tried to take out the canal on a patient on the wrong foot, so I've definitely had a few can I say minor mishaps? No, that's terrible. There were and have been a few potential mishaps in the world. So please to be very cautious about this. That's why the surgical safety checklist is there. As we know, it was based on the same list that the pilots do, and I think it's a very important concept. What I noticed in the ARN surgical safety checklist, which you can download for free off the website if you search for it, is they include a fire risk assessment and discussion. And in fact, that video that I was discussing now that I watched, it was an ENT procedure, and they were concerned about potential fire in the throat being near the ET tube. And the scrub nurse described how she would manage the scenario. If should there be a fire, I will douse the patient with this bulb of water. The anesthetist said, I will remove the drapes off the patient, and each one described out loud that should there be a fire, what their role would be under those circumstances. Surgical fires are close to my heart. One of our hospitals in the Cape recently had a fire, and I was quite nervous that it was in the operating room, but it wasn't, thankfully. So I'm very grateful for that. But fires are truly a reality. In my own experience, I've had two instances, one where the drapes caught fire because of the fiber optic cable, and one where the surgeon was impatient and didn't wait for the prep fluid to dry, and the patient caught fire when he stood on the diathermy. We couldn't see the flames. They were clear, but we could smell the burning, which was quite scary. So when we realized that the patient was burning, or of course all we could do was douse where we thought the flames would have been on the abdomen. Thankfully there were no serious repercussions. We did put a fire extinguisher in the surgeon's theatre for a week thereafter, just to remind him of the importance of being patient. In my brief search in the operating room Association of Operating Room journals on fire safety, I came across 3 articles quite quickly on the importance of surgical fire safety. The article at the top, Fire in the Hole, an OR fire, refers to how rare operating room fires are, and they estimate it to be about 200 to 240 a year in the US. Would be very interesting to hear South African statistics. I really don't know of them. Although the incidences are very low, the consequences are so drastic, so I really don't think it's something that we can afford to play with. Thank you, Nanette. Sources of fire, I'm sure you all know this very well, and Briette spoke about it last week as well, about the importance of the humidity in the theatre. If the humidity is, which was it, too low, as I remember correctly, then there is a greater chance of electrostatical issues and the potential for fire. So common fuels in the operating room, of course, are patient's hair, patient's tissue, and intestinal gases. Anesthesia, of course, working anywhere near an ET tube is always a problem. PrEP solutions, as I've experienced firsthand, and petroleum-based ointments. Surgical equipment, again, like I say, for me, I've had the fiber optic cable catch the drapes catch light as a result of it, and drapes, dressings, and swabs, because of course we need oxygen, we need heat, and we need a fuel source in order for there to be a fire in an operating room. Thank you, Nanette. As we know, when we're doing these webinars, a lot of the information comes from the work that I do in terms of journal researches and that I do on a regular basis, because it pays to be up to date with what's happening all around us. And of late, I've come across quite a few presentations and articles in various journals around spinal surgery and the risks associated with spinal surgery, and of course the can be high rates of surgical site infections relating to spinal surgery. So in the next few slides, we're gonna focus on spinal surgery. The first one is a paper again in the ARN that looked at risk factors and prevention of surgical site infections following spinal procedures. If you take a look at the graph, they divided them into patient-related and procedure-related. I focused on some of the topics, not everything listed in the article. Patient factors, which we all know quite well, of course, smoking, obesity, or previous colonization with MRSA are certainly going to increase the potential for surgical site infections with spinal surgery. Procedure-related, I thought these were quite interesting. Skin prep, yes, so there's a lot of work on chlorhexidine bathing and a variety of methods to improve our skin preparation. The operative time, we know that, we've known that for a long time. And in this particular article, they referred to staff turnover. I thought that was really interesting. Perhaps in the US, they for whatever reason, they're changing staff during spinal surgery. Thought that was a bit odd, but I don't think it's something we do too often. And one could understand that there's an increase of surgical site infection when there's nursing turnover. It will increase the odds, or because of course there's also increased traffic in the operating room. Another reason why we might want to, from safety's sake, finish our procedures where possible ourselves. Of course, patient positioning is also very important, and we want to reduce the amount of time that the patient spends on the table. We've just understood that increased operative time and increased time in the theatre is going to increase the patient's risk. So to do that, we want to make sure that we position our patients as carefully as possible. And so what table features are going to matter around that when you're thinking about patient positioning? Obviously, a table that's adaptable to the surgical discipline will be really great. If there's one that works well for orthopedics, spinal surgery, and gynecology, well, then that's kind of the angle you might want to think towards, depending, of course, on your circumstances. A table that can handle the weight of the patient, no matter what angle the patient is at, that matters quite a lot. A table with the correct and a multitude of positioning accessories will be very important. If you're talking about spinal surgery or orthopedics, then radiolucence becomes quite important. And often the shift of the table matters because, whether or not you can get a C-arm under at the right angle in an area that's now radiolucent becomes very important. Breaks on a table always from a safety perspective are going to be important. We might have uneven floors, so we need a table that's going to be sturdy. We definitely don't want our table bossing around the operating room. And a table that's going to function depending on the circumstances. If maybe the table hadn't been charged or the remote's not working, do you have an override system? What safely can you do to look after your patient under those circumstances? Of course, then we also want to protect the patient carefully when positioning. This is a topic you know well. In next week or the last one, we'll focus on nurse injuries around ergonomics and the movement of patient in terms of patient positioning. So putting ourselves at risk when it comes to patient positioning. Needless to say, we want to protect the skin, we want to protect the joints, as you know, we want to protect the nerves, and we want to protect the circulation. And in order to do that, we need all the right table accessories that are going to protect our patient. Terry McCauley has been in South Africa a few times and presented for the CFSA at Africa Health. And one of the topics she relates to and discusses is, in fact, her master's, which was around screw caddies. And what she did was she took a series of control screws and screws in screw caddies that are used over and over and over and over again, put them under an electron microscope, I think it's called, is the correct term for it, and then had a look at what those screws looked like. So she had the controls and she had the ones that were in the set that had been there for however long, you know, those trays that end up going through CSD that we barely clean, and we sort of replace the missing ones and hope for the best. And sometimes they go through the washer in the box, sometimes they don't see a washer. It is of great importance to think about those type of screws that we use. In her findings, which I agree are pretty alarming, there were 30 screws in total that she looked at. 28 of them had some form of debris. She then goes on to define some of that debris. Fibers were present on 16 of them. If you have a look at the image up the top left, you can see what looks like a hair or a fiber of some description. So that's definitely ready-to-use sterile screws that she assessed, as you can imagine. So that would have been a foreign body in somebody's spine. Fretting, where of course meaning that the metal was starting to break down. That was seen in 6 of the 30 screws. Black specks were seen on 14 of the 30 screws, and heaven only knows what those black specks were. Again, that can be seen on the image on the right. Of course, contaminants on the control screws had started to develop, but there were less contaminants on those control screws. And the more the screws are being processed, the greater the number of contaminants. That does make logical sense. Talking about sets, and spinal sets are one of the things where we have humongous amount of inventory, and often, as you know, you get to the end of the day and we've used 15, 20, 30, depending on the case, maybe up to 60% of the instruments in a given tray. Although it is very important to have everything that you need on hand for a particular type of surgery and that there is sufficient instrumentation, it is quite a tricky scenario because we do tend to waste a little bit and we end up with way more instruments than we need on our trays. And reducing and streamlining the number of instruments in your trays is a very valuable concept, something that can save you money and also talks to patient safety. From a CSD perspective, it does decrease the time it'll take to reprocess those trays. It'll reduce the labor required and, of course, the consumable costs. It reduces the weight of the tray and the physical strain. As we know, surgical instrument trays should not weigh more than 10 kilograms, and that includes the tray or the container that it's in itself. I've weighed trays up to, especially in spinal, I have, up to 18 kilograms, I think was the heaviest I've ever weighed, and the lowest in that arena normally around 12 kilograms, and there shouldn't be more than 10. But to help reduce the weight, help reduce the strain on the individuals and the staff themselves, and of course by taking off the instruments, the extra instruments, you've got additional inventory to use in other sets or create other sets with. In the operating room, it takes less time to count. Your setup time should be a little bit quicker. It does increase your turnaround time, the likelihood of loss or misplaced instruments. Now, this is not information I'm sucking out of my thumb. This is all coming out of the article, again, published in the ARN in 2019, Best Practices for Streamlining Your Sets. From a safety perspective, it would be great if it decreases the likelihood of lost or misplaced instruments. I think from a patient safety perspective, that matters. It is really a challenging process, and it does require input from the operating theatre and the CSST. CSST can never do this alone, because obviously only scrub sisters know what they need and what they could possibly give up. A lot of buy-in, both from the scrub staff and the surgeons, and of course our just-in-case mentality. We have a lot of stuff on standby just in case we need it, for good reason, because often we've experienced difficult things, and we know that for the sake of safety, we do need some extra stuff on hand, but perhaps we can find better ways of managing that and decrease the stuff that's in a particular tray, have some stuff on standby that you can open if you have to, but you don't really open standard, which really would be useful. Streamlining sets. Now, which one do you do first? It's a process. We'll look shortly at the next slide, which will look at that. But you need data. You need to be able to know how many sets you're using, which sets you're using the most. If you've got 6 gynecology sets, are you not using tray number 6, but you're using 1 to 5, and why are you not using tray number 6? Why are you overworking some trays and not working others? And that often talks to an instrument management or a tracking system of some sort. Thank you, Nanette. In this published paper, they found that they did a survey amongst their hospitals in the US and asked, how do you prioritize which trays you should streamline first? And as you can see, they began by the highest approach was the sets that were used most frequently by all surgeons. So that's a lot of work, because it's quite brave. You're tackling those trays that are used the most often. If you're scared to do it that way, then I guess you could start with the trays that are used the least, from a less intrusive way. But the most cost-effective way is to look at the sets that are used most frequently by all surgeons. The sets suggested by the surgeons, as you can see, that it's one of the ways of doing it. Following the suggestions of the scrub staff or the suggestions of the sterile reprocessing team, the CCT staff, is also another way of trying to decide which sets do you tackle first. Thank you, Nanette. So back to spinal surgery. If you think about spinal surgery, of course, we really are worried about surgical site infections no matter what the discipline, but it really isn't great for spinal surgery. And I thought, let's tackle the issue of scrubs and wearing your scrubs outside of the theatres. And we know we struggle with our surgeons, and then there's the overgown, and then there's no gown, and then there's the overshoe, and then we change the overshoe and we never wash our hands. Or should we be wearing the overshoes? Or are these just old adages that we continue to do for years and years without reassessing or rethinking our practices? So this paper was covered bacterial contamination of surgical scrubs, published this year in 2020, where they took some specimens from the scrubs of surgeons, worn by surgeons, as the surgeon's about to enter the operating room. They then asked the surgeon a number of questions. So where were you in the last 4 hours? What were you doing? What activities were you involved in? And then they went ahead, thank you, Nanette, to test the scrubs. So there were 133 surgeons that were involved in this. And amongst that, as you can imagine, colony forming units was higher for the scrubs that the surgeons were wearing versus the control group of clean scrubs. Okay. The paper said that there was no significant difference in the study group and the control group in the rate of carriage of pathogenic bacteria, 13 versus 9%. But as a matter of interest, 41% of the doctors were involved with medical activities, 34% were not involved in, or were involved in non-medical activities. Not sure what the rest were doing. So the non-medical, obviously going to have lunch or something of the sort, and medical dealing with another patient somewhere or something of the sort. Obviously, those who were practicing medical activities, as we would expect, had higher colony-forming units compared to those that weren't involved in medical activities. Thank you, Nanette. It does say, the conclusions say that surgeon scrubs don't carry a high bacterial pathogenic load. However, it does say when the scrubs are replaced quite frequently, and in this case, they were looking at an average of 4 hours. Also, the other thing to bear in mind, though, is that there are many other previous studies about how contamination rates on the uniforms of nurses and physicians working in other departments and other areas of the hospital, including the linen and the bedding, etc., etc. So I think those are important to bear in mind, and it does, as they say clearly, strengthen the guidelines about wearing separate scrubs in the operating room and changing them frequently. How does this help us with the overgown? You're going to have to think that through, I think. So it's a question of contaminating scrubs outside of the operating room, I think, and seemingly when we're in the operating room, perhaps they aren't themselves being too badly contaminated. Thank you, Nanette. Right, moving on to these next 4 factors that I want to talk about, and they are very much interrelated, and they relate to COVID-19, the backlog of surgery, burnout as a concept, and patient safety. And I think they are all interrelated. So I'm going to look at 4 different articles and how these all affect patient safety, a very important concept. First of all, this published paper again in the Association of Operating Room Nurses about what protocols they adapted in their operating rooms because of COVID-19. And in this particular paper, they refer to the fact that they made the decision to treat all patients as positive. As we've spoken about this before on the webinars, managing the intubation, only having the anaesthetist and the anaesthetic nurse present in the theatre during intubation, intubating using the box or the shield to try and reduce the spread of contamination, wearing high-level PPE, N95 masks, in some cases 2 pairs of gloves, gowns and face shields, scrubbed or not scrubbed, and having a runner outside theatre. And in the US, they also talk about allowing 30 minutes for airflow turnover between cases. So a concept that they seem to have embraced. And all of that is costly in terms of expense, of course, and time, really, really time consuming and stressful. I think stressful for everybody concerned because you never know now here's another virus or another bug you potentially can get. It's bad enough we've had to deal with hepatitis and HIV already. Thank you. I'm not sure if any of you know ECRI. ECRI is an independent non-profit organization, and their whole goal is improving the safety, quality, and cost-effectiveness of care across all healthcare settings worldwide. And they were founded in 1968. If you belong to ECRI and you pay large amounts of money, you can get really fancy reports out of them. If you can't afford that, you can Google ECRI and you can get the pricey versions of quite a lot of stuff, which is quite useful and really, really handy. They have additional reports like the top 10 health technology hazards for 2020. That's one that I always follow. The top 10 patient safety concerns. That one I'm new to. And Nanette directed me towards this third one on strategies for surgical patient safety. One of the ones that I want to refer to is this burnout. By the way, the top 10 health technology hazards, we will delve into that in a lot more detail in webinars 4 and 5. Burnout was one of the topics that they refer to in I think it was, where it came in number 3 as one of their higher concerns. And I think it's really a really valid perspective. And studies show that burnout has a consistent negative relationship with safety and quality. And in order to address burnout, there are a number of things that organizations have to listen to, and it includes listening to what the staff have to say about workload, what they have to say about resource allocations, and you have to understand all of those things. You need to help fix the system to help deal with burnout, because burnout in itself is, as we know, a terrible concept, and it's going to have a huge impact on patient safety. Thank you. In the paper at the bottom left-hand corner, elective surgery cancelled due to COVID-19 pandemic and global predictive modelling. So this came out, I can't remember now, it may have been June. And these are the statistics that refers to South Africa. And I think the backlog's probably even worse. So this was in the British Journal of Surgery, and globally the estimate was that over 28 million operations would be cancelled because of the peaks during COVID-19. South Africa, the guesstimate in this paper was 12,795 cases per week. It's a lot of surgery being avoided. If we go into lockdown again, and of course our numbers are going up again, so people are a little bit nervous. We haven't convinced all patients to feel safe enough to come back to theatre anyway, so our surgical numbers are a little low as it is, which in itself is worrisome. But when it does come back, it is going to be quite a huge workload. In this particular article, they refer to the fact that even if you increase your normal surgical volume by 20%, it's going to take 45 weeks to clear the backlog. So it's going to take 45 weeks to clear the backlog of surgery. That has a huge impact for a number of reasons on our mental health, on our patient safety. And at the end of the day, as we know, these are all interrelated. Thank you, Nanette. In the article from ECRI on strategies for surgical patient safety, they refer to the following statistics: that surgical care is a large proportion of our healthcare volume, and that 7 million inpatient stays were for surgery. This is already 2014 statistics. So there was 20% of all inpatient stay related to surgery. Okay. If you look at the volume of procedures and coupled with the potential for harm, surgical patient safety is a very important patient safety matter. And 10% of all surgical patients in hospitals experience at least one adverse event. Wow, that's something else. The risks obviously include things like complications, infections, wrong site surgery, and other mishaps. If we now take a look at the graph that they refer to in the paper, these are the 6 aspects that they rated in terms of worrisome and where most things go wrong. So surgical complications, although that's a group, they didn't drill down into what that meant. Patient and operating room readiness. Wow, that is tricky. Okay, something we can do something about. Retained surgical items, also quite high, and that's again something we'll talk to in the next 2 webinars. Contamination, of course, so that's our instruments and our screw caddies being dirty. Equipment failures and wrong site surgery. Thanks. Right, winding up and coming to this last aspect, something I find in the Association of Operating Room Nurses Journal, more so than most journals, is they really have a really good focus on mental health well-being, and those approaches in the operating tend to student nurses. Honestly, nobody ever taught me any of these aspects, which I think could have helped. Perhaps that's why our theatre staff and ICU staff, have lots of emotional outbursts, are known to be horrible people. And maybe if we learned a few strategies, we'd be better off. And in June of this year, they published this article on using emotional intelligence to improve the perioperative teamwork. I think if I remember correctly, in one of the APSA journals, it speaks to the fact that the nurse must be subservient, or at least it used to, and that's how we solve the conflicts in the operating room. So I'm sure we can find better ways of managing things now. Emotional intelligence, of course, is the ability to manage your own emotions and also try and manage the emotions of others. I'm not doing too badly on my own emotions, but I can tell you I'm not great with the emotions of others. It's important to understand your own emotions, your own strengths, your own what triggers you the most. And I think COVID has probably taught a lot of people a lot of things about themselves around this. Being able to understand why your teammates are responding negatively to a particular given situation is really important. When we often do, the surgeon goes a bit ballistic. If there's a whole lot of stress and stuff around it, we tend to manage that. But of course, if your teammates start behaving badly, then that's really quite problematic. Thank you, Nanette. So I do believe these 4 factors are going to be interrelated. We've got COVID-19. It's not going away. We're going to have to be wearing our masks for a good couple of years. We're not getting a vaccine in a hurry. And even if the vaccine's made, the question is how we're going to distribute it around the world. There is a backlog of surgery for a number of reasons. Patients are scared to go to surgery. Patients are not getting their cancer diagnoses, and the impact of that will be huge on those of us in the operating room. Staff already in a burnout scenario because we're scared enough of the COVID, plus our surgical cases have dropped, so we're all still trying to keep our jobs, but we know that there's still a backlog to come. And all of that at the end of the day is going to impact patient safety without a doubt. Thank you, Nanette. So in summary, what have we spoken about today? We spoke about preserving the keenness of your surgical blade, and we'll talk about managing sharps safely in 4 and 5 as well. By the way, Nanette and I have managed to book an appointment with some future surgeons at TICS. So I think they're mostly 4th years. So we're going to spend some time teaching them how not to stab any theatre nurses next week, which I think is really a good place to start to try to keep ourselves safe. We spoke about surgical pause. We spoke about timeout. We spoke about fire safety. We spoke about risks related to spinal surgery. We focused on adverse events and surgical patient safety. And we spoke about emotional intelligence and how these things can helpfully help us improve our ability to take care of our patients and ourselves to reduce risks for everybody. Thank you, Nanette. Right, what are your take-home points, Nanette?
Thanks, Anna. Once again, it's like listening to you. I think the theme of care is important, and it's something that we often miss over just because of being rushed. But I think important taking care of yourself in this environment and these times is very important. And we salute everybody that's in the field, but please do take care of yourself and the strain of managers taking care of your staff. But basically taking care in everything that you are doing. And care is not just, it's making sure that you are safe, making sure that the patient is safe and making sure that the situation is safe. All those things can help decrease your risks over the long period and over the long time. And bringing it back to bad habits is, if you have bad habits, take care to get rid of these bad habits. Thanks.